My name is Gary Barahona and I'm going to talk about acute osteomyelitis in children. Introduction. Bacteria may reach bone through direct inoculation from traumatic wounds by spreading from adjacent tissue affected by cellulitis or septic arthritis, or through hematogenous seeding. In children, an acute bone infection is most often hematogenous in origin.
It's a condition that can strike an otherwise healthy child, but knowing the symptoms of osteomyelitis can make the treatment much more manageable. We find out more in today's Health Matters. Bacteria, it not only lurks on doorknobs, keyboards, and playgrounds, it lurks in our bodies, whether we like it or not.
Everyone has a little bit of bacteria traveling around their system, and that can be caused by something as benign as brushing your teeth.
Sometimes the bacteria can travel into the bloodstream and affect the bones, a condition called osteomyelitis. Children are the most vulnerable. Pediatric orthopedic surgeon Dr. Matthew Wagner demonstrates how a child's knee can be affected.
They have leaky blood vessels. The endothelium are the cells that cover blood vessels, and they're not as tight, making this transient bacteria that's in all of our systems a little bit more likely to exit in these areas. The knee, in a skeletally immature patient, is affected in over 50% of spontaneous acute hematogenously spread osteomyelitis.
As Dr. Wagner explains, the bacteria can spread dramatically.
Once it has established itself within the bone itself actually has a network of what's called reversion canals that allows cells within the bone to communicate with each other. The bacteria can then use that to communicate.
That's when children start to show symptoms.
Probably one of the most common is pain in an extremity, limp, especially in young children where they can't tell you, "Mommy, it hurts here." You'll see them favoring one leg. Certainly there can be swelling, there can be redness over the area, and fever. These are some of the more common symptoms.
These symptoms should not be ignored. Osteomyelitis can be treated with antibiotics. For those with more severe cases, surgery may be in order. Reporting for Lee Memorial Health System, I'm John Lafar. Infants can also be affected. The infection can spread to the joint and cause arthritis.
Diagnosis and treatment. If physical examination suggests bone involvement, further tests are performed. Serum C-reactive protein, CRP, and procalcitonin levels are sensitive as diagnostic tests and useful in follow-up. Declining levels of CRP usually suggest a favorable response to treatment, even if the fever continues, since the erythrocyte sedimentation rate increases rapidly but decreases significantly more slowly than the CRP levels. It is less useful in monitoring the course of the illness.
There are bacteria everywhere. If bone is exposed to dirt, water, or even air, microorganisms may seed to the bone, begin to grow, and cause an infection. Bone may also be exposed to microorganisms in open sores and overlying soft tissue infections. People with diabetes often have sores on their feet that can become infected. Orthopedic implants such as plates, screws, and knee replacement prostheses make good places for bacteria to grow. The second way that osteomyelitis occurs is when microorganisms travel through the blood until they are able to settle in the bone. This is known as hematogenous infection. Often, this occurs because bacteria from another infection in the body travel through the bloodstream to the bone. Whatever the cause and whatever the source, the infection can begin to eat away at the bone. This can result in pain, loss of function, a collection of pus known as an abscess, and dead bone. Osteomyelitis is not usually visible on x-rays for several days after it begins. It will show up earlier on MRIs or bone scans. Blood work is also important. The white blood cell count is usually high. Lab values known as the erythrocyte sedimentation rate, or SED rate, and the CRP, C-reactive protein, are usually obtained when osteomyelitis is suspected. If they are high, it raises the doctor's suspicion of infection. These lab values are monitored as the infection is treated. If they drop, it is an indication that the treatment is working. Treatment depends on what bone is involved, where the infection is located, whether an abscess or dead bone is present, the age of the patient, and other factors. Treatment often involves surgery to remove infected bone and soft tissue. The affected area is thoroughly irrigated to wash away the bacteria and pus. The infected bone is then sent to the lab for analysis. Within a few days, the bacteria can be grown in a culture in the lab and tested with different antibiotics to see which antibiotics are most effective at killing it. While the doctors wait for these culture and sensitivity results, they can only make an educated guess as to which antibiotics will be best. This is known as empirical treatment. They make this guess based on what types of organisms have caused similar infections in similar patients. These antibiotics are usually given through an IV. IV antibiotics are often necessary for several weeks after the infection is discovered.
Role of surgery. Since data are lacking from randomized trials of surgery for osteomyelitis in children, questions about the timing and extent of the surgery and the overall need for surgical intervention other than biopsy remain unanswered. Conservative treatment is effective in up to 90% of cases of acute osteomyelitis if it is diagnosed early in the course of the illness. Antibiotic treatment. Treatment of acute osteomyelitis is also almost always instituted empirically before the causative agent and its resistant pattern are known. The adequacy of bone penetration is a concern when vancomycin is used, and measurement through levels is warranted to guarantee sufficient dosing. In conclusion, clinicians tend to prolong or reigns due to antibiotic therapy and often recommend surgery in patients with a pathological fracture. One should, however, distinguish active infection in which bacteria are still alive from inflammation. In much lengthier process, spontaneous healing was well under 1 month after discharge and no fistula have developed. The normalized CRP levels and erythrocyte sedimentation rate virtually rule out ongoing active infection. Thank you.